diseases in our country, Penn Medicine is at the top. The CDC routinely looks to Penn Medicine for their thought leadership. Back when Ebola came around, we were one of the 3 or 4 places in the country prepared to take Ebola patients. And so Dr. Akhter's in the middle of all that, and when COVID hit, we were in the great position of having faculty, infectious disease people guiding our every step. So technically she's an expert, but I think the thing I'm prouder of is that she is absolutely fearless in gowning up, rolling up her sleeves, putting whatever layers of PPE on she needs and going to the bedside at a time when a lot of clinicians are afraid to get in that space. So she's both, will give you both technical excellence, but also practical guidance of what you need to do to keep your folks safe. So with that, I will turn it over to Dr. Akhter. Shafinaz?
Thank you, Mike. So I was going to start with a little presentation, right? Does that seem reasonable, Meredith?
Yes, please. There's a little feedback on your sound, so I don't know if that's for you.
I don't know where that's coming from.
Oh, it's better now. So maybe.
Yeah. It might be when Mike got off. So I'll start with the presentation. I will absolutely welcome questions throughout this. I again, interacting with people is the best part of this job, and anything that's the more interactive, the better. I'll get through what I can get through, and we will talk about, have a conversation throughout this. Much preferred. I did receive the questions in advance, and I've tried to address at least some of them in the presentation itself. Couldn't get to everything. There's a lot of information, clearly, but I'm happy to, if we have time later. And I put my email address down as well. So I'm happy to have people reach out to me later. So I'm going to bring up my presentation. Can you guys see it okay?
We can.
Okay, terrific. So this is an update on COVID, and here's my email address. And those of you who can't jot it down this quickly, I'm sure it can be shared later as well. I'm happy also to send my slides out later if you guys would like. So I'd like to start out with some sobering numbers. And this is just part of the story, but I have to remind myself of the numbers regularly to know exactly what's the face of this pandemic. So this is information from the Johns Hopkins database. And what you can see is that globally, we are now surpassing 40 million cases of diagnosed COVID. In the United States alone, we have 8.5 million cases, and we have 225,000 deaths as of yesterday morning. So there is and continues to be an enormous burden of disease in this country and the world. This is data that comes out of the CDC. There is a great source, and one of my questions was, what are good sources of information? And I would say that the CDC has a newsletter it puts out once a week called COVID View, one word, that goes through the statistics. You can get it emailed to you, and it's really a helpful snapshot of what's happening in this country. And what this tells you is, in the blue solid bars is the number of tests we're doing. And so we're doing a lot of tests in this country. And what the lines show you is the percentage positivity by age group. And when you looked at the beginning of this pandemic, what we see is the gray lines, and that's folks over 65 really peaking at percent positivity of over 25, 30%. But what you see as time goes on is that group has now come towards the bottom in terms of their percentage positivity. And what we see is people between much younger, less than 30. So the green line, for instance, which is folks of 5 to 17, or the 18 to 49 age group, really picking up the speed of the percentage positivity. However, despite the fact that more young people are now turning positive, our hospitalizations still remain disproportionately in the older. And what we see here is in that dark blue dotted line is folks over 65 still being hospitalized at a much higher rate than those younger. So the burden of disease, while it is younger people, is still occurring in our older folks. This is a recent CDC MMWR, or Mortality and Morbidity Weekly Report, that came out that looked at the changing age distribution of the COVID-19 pandemic. And what you can see here on the left axis is the median age, really of a number of things, including ED visits, percentage positive SARS-CoV-2 testing and confirmed tests. And what it really shows you is that our average age of people who are currently testing positive and going to emergency departments is dropping precipitously and now is heading to 35 or lower in terms of people turning positive. So one of the questions I received is, why are we seeing an increase in cases around the country? We're seeing an increase in cases in young people. We're seeing clusters of people going back to school. So outbreaks in college campuses, as we saw here, even though school is all virtual, undergrads are congregating in rental communities. They're spending time together. And that's a large part of why we see an increase in cases. People are becoming fatigued of isolation. I suspect we'll see more cases over the holidays as families congregate. But really, it's turning into a disease of young people who are slowly spreading it to their more susceptible family. This is my last epidemiological slide, and it shows you by year, over several years, what's happened in terms of the number of deaths in the red from PIC, which stands for pneumonia, influenza, and COVID. And you can see in previous years, we've had spikes before, as in 2018, we had a bad influenza year. 2019 was not too bad. But if you look at this number, it really gives you an idea of how much more disproportionate death we have had. In the solid blue, you can see the number of COVID-coded deaths, and almost all the mortality is clearly coming from people who've been identified as having COVID-19 infection. So what can we expect as we come into flu season in the midst of a COVID pandemic? As in most things with this, we don't know. In the Southern Hemisphere, we saw very little influenza activity, which was a blessing, but it's going to be very hard to tell them apart. COVID, flu, RSV, rhinovirus can all look very similar. And so our challenge in the next few months is going to be being able to test and identify those who have COVID from those who have flu or other respiratory viruses that can look very similar. So how do you acquire COVID? How do you acquire COVID, or SARS-CoV-2, which is the name of the virus, and the illness is COVID? So the main means of transmission of COVID remains droplet isolation, which is defined as large particles over 5 microns going from an infected host, as you see on one side, to a susceptible host on the other side. And these viral particles, which are large and don't travel very far, have to land in a susceptible area. So the eyes, the nose, or the mouth. I see people outside wearing gloves sometimes when they go shopping, and the virus does not enter through intact or even abraded skin. It really has to enter through the mucous membranes where we have the receptors. So when we say spread through contact, it's really you touch a contaminated surface and you touch your eyes, nose, or mouth. And that's how the means of transmission are. There is increasing talk about aerosol and airborne spread, but really it's felt to be a very minor means of transmission. And we have seen case reports, but it's really been restricted to case reports. So one of the questions I received is, how important is cleaning and what is the best time to clean? And to be candid with you, while COVID or SARS-CoV-2 does survive on surfaces, in varying different types of surfaces for different periods of time, you would literally have to touch the surface and touch your eyes, nose, or mouth to transmit the infection. And so while that certainly can happen, especially with younger children or cognitively impaired individuals, it's not the main means. And we certainly support cleaning, but that's really not going to be how we stop the spread of this virus for the most part. There's some information on urine and feces. We know they can be identified, especially in the stool. But again, outbreaks or even clear cases transmitted through stool have not been well documented. So here's some of the take-home points on the modes of SARS-CoV-2 transmission. Person-to-person transmission is almost entirely through respiratory droplets. And we know talking releases aerosols, coughing, sneezing, singing is a very good way of transmitting the virus. High level of viral shedding is in the upper airway tract. And we know that people who are asymptomatic or pre-symptomatic have just as much virus as those who are sick, and often more virus than those who are sick. Airborne transmission has been suggested, but really not well established except in a very few outbreaks. We know that virus is hard to find after 9 or 10 days after symptom onset, even in those with more severe disease, so both mild or more severe disease. And because of this means of transmission, which you can see in an enclosed environment is almost 20 times more likely to happen than in an outdoor setting, in an open air environment. And that's really because people congregate closer together and there's poor air circulation. So 2 more questions. Given the possibility of aerosol transmission, how can we safely proceed with indoor gatherings? And really, it's paying attention to not having a poorly circulated area, having windows open is important, having a means of air circulation. Having people distanced still makes a big difference. The farther apart, the better. We say 6 feet somewhat arbitrarily, but really, the farther you get, the safer it is. And wearing masks for everybody involved. What are the risks posed by singing or humming? Well, again, the more you project your voice, especially without wearing a mask, the more likely you are to expel respiratory droplets. And so we know people who talk more loudly expel more respiratory droplets than those who don't, So it's all across the board, So if you're a low talker, you're actually good for COVID. I thought this was a particularly interesting study that happened. It's one of the cases that was highlighted as being evidence of airborne transmission or aerosolized transmission. And this is actually a restaurant in China. And you'll see the patient 0 is the one in table A. And when they looked at how the virus was transmitted, they actually saw that the air conditioning was flowing through that area, but also they were really in very close quarters. And in fact, none of the waiters who served these tables but wandered around the restaurants or the other tables or patrons became infected, which you would have expected if it had been a virus like measles, for instance. You would have expected everybody to be infected. So really suggests that aerosol transmission can occur, but you need the perfect conditions for it. So think close quarters, poor air circulation, people crowded together without masks. I was asked about this idea of herd immunity, which comes up often. And this is a pictorial depiction of herd immunity. And what you see in the top figure is largely what we have going on now. The R0 represents the replication index, which means how many people you are likely to transmit the virus to. In the top scenario, you see a very susceptible population. So one person transmits it to 4, who transmitted to 4 and onwards. In order to prevent transmission in this scenario where your R0 is 4, you would need to have at least 75% immunity, which you see in the bottom scenario. So again, transmission is blocked when you have people who are immune, but you need high levels of immunity to stop transmission when you have higher R naughts. It's difficult to exactly pinpoint the R naught for COVID. We think it's probably between 2 and 3, but it really depends upon if we have good testing and case isolation. Various epidemiological models, as I say, currently suggest, I've seen 60% probably the most often quoted number in order to get herd immunity. So we looked at that first slide, we had about 8.5 million people infected. Well, in the US, you would need 200 million people infected in order to have herd immunity be effective. And that's a whole lot of mortality, and especially of older people. It's very hard to say who exactly is going to be getting the virus. I was asked a question about testing. So when we think about testing for SARS-CoV-2, we think about mostly two modalities. The first is a PCR test, which is actually looking for the presence of the molecular material, RNA usually, in the nose or the mouth of an infected person. And what you can see here is that if you look at the x-axis, this is symptom onset, you can see that people start shedding virus a day or two before they become symptomatic. And sometimes they never become symptomatic. At that point, even before they become symptomatic, their PCR or their nasopharyngeal swab turns positive. And it will then stay positive for a period of time. The average is about 20 days, we think. Even though the PCR is positive, people stop being contagious at around that 10-day time period. So you see the PCR turning negative after that. Antigen testing, on the other hand, which is another means of rapid testing, is less sensitive and is actually probably not positive until you are symptomatic and about a week afterwards. So has a narrower time frame. You're more likely to miss people earlier on in disease when they may still be contagious. And finally, there's a whole lot of interest in antibody testing, and you see really doesn't kick in until about 10 days after infection. We don't know how long it lasts. Some people never make antibodies, others make antibodies, but predictably, within a few months, everybody's antibody level drops. Between 2 to 3 months, we see a significant decline in almost everybody's antibody level. That doesn't mean that you become susceptible to infection in 2 to 3 months. In the 10 months or so we've had this illness, we've documented less than 50 people of the 44 million infected who've been reinfected. As infectious disease doctors who've studied coronavirus for some time, we expect that people will become reinfected, but it probably will be immunity for at least 10 months, maybe a year if we're lucky. So what this says about vaccines, and I didn't actually put in a slide on vaccines, and it's because it's so extremely confusing. There's many platforms. The most likely ones are probably the Pfizer mRNA platform. In reality, again, when part of all these task force, the first vaccine is not even going to be submitted for emergency use authorization until the end of November at the earliest. We don't anticipate rolling out even testing to our most susceptible healthcare populations until December or early January. And in terms of large-scale production, we really don't think it's going to happen, in my opinion, until the spring or summer of 2021. In addition, we continue to consider, I think, appropriate concerns for safety and effectiveness of the vaccination. As most of you know, with flu vaccination, 70% is a terrific effectiveness. We're very happy. In older people, even with good flu vaccinations, we see numbers like 30%. So don't be surprised if you see a wide variety of effectiveness. It's very unlikely to be any more than 70 or 80% effective. And we're going to have to live with COVID for a long time in some form or another and make our new normal from it. And finally, my final thoughts. I love this picture. It was from 6ABC, and it's like the sports team. So they put pictures of the congregation. And Mike's right. Probably the most important thing I do is not the science. It's that I am personally not afraid. I'm personally not afraid of sick people. So I feel comfortable putting on the PPE that I believe in, going and sitting in a patient's room with COVID and holding their hand. And that's probably the hardest thing for me to see, and the most important message is how isolated people feel. They feel stigmatized. They feel like they're treated like lepers. They feel like they're made to feel like they've done something wrong. And many of them are isolating and have difficulty returning to even the limited activities they were doing before this pandemic because people are afraid of them. And we have a big role as a medical community and outside. I spend a lot of time taking care of HIV patients, of removing the stigma from this particularly susceptible group of people. So that's it in terms of my prepared remarks. I'm happy to take any questions or anything else you may have. And I'll stop sharing. Or I will try to stop sharing. I don't know if I can.
Well, if you would put your questions in the chat room, we have quite a few people on the call, and that way we can make sure that we see and hear your questions. And so go ahead and put your questions in the chat room. Dr. Akhter, I really am grateful for your, those charts are very helpful to see the pictorial representation, because I think with so much, there's been numbers being thrown out there, and especially with the herd immunity, I thought that was very helpful. I'm looking, I think you have answered all the questions that we had sent you, so that is very helpful. So any new questions or any conversation that y'all would like to have? You mentioned circulation. Are ceiling fans okay or not?
A good question. It really depends if there's movement through the room. So I would say yes, for the most part. But if you're in a closed, crowded space and you're just circulating the same air, then that's problematic.
Is it possible to shed the virus before one's test is positive?
Yes, and that's been the most challenging part of this in terms from a public health perspective. We know that people start shedding the virus usually 24 to 48 hours before they develop any symptoms. In addition, we know that at least 30%, in studies up to 50% of patients are entirely asymptomatic. And so it's that key period before development of symptoms and the large proportion of people who never develop any symptoms that are really working to fuel this ongoing pandemic. In the case of SARS-1, it was a very severe virus, very high R0 value. But by the time you were infectious, you were very sick and you really were identified and isolated early. And that's been probably the biggest difference for us is that, I have a list of our positive employees. And the question I hear the most often is, I can't believe I'm positive. I thought it was just a sinus infection. The vast majority of the time, people are earnestly, truly surprised. And I actually look at our viral load. That's one of the benefits I have here. And I find that our asymptomatic or minimally symptomatic young employees have very high levels of virus, much higher than the average sick patient coming in, actually.
Wow. How long after a positive test can you spread the virus?
So we think that the average period of infectivity is 10 days from symptom onset. So this is not from when you're tested, because people take a while to get tested and the results take a while to come back. But really from symptom onset, we have not been able to isolate live virus after 10 days or so. This is, of course, very interesting in that people can be PCR positive. I've seen 6 months easily. 6 months of being PCR positive. And really, they stop being contagious at day 10. But they're terrified, and it scares people to have testing and have it come back positive time and again and again.
Thank you. Brooks, when Dr. Akhter said we should be ready to live with COVID for a long time, do you have any long-term ballpark estimates as to what long time could be? In other words, how much longer do I need to schedule my Zoom makeovers?
Oh my goodness. This is going to be a part of our healthcare life moving forward. COVID's not going to go anywhere. It's going to be either a circulating respiratory virus in the winters, or it's going to be endemic throughout the year. But the chance of us completely eliminating COVID for years is very unlikely.
HVAC systems filters should be done before HVAC system filters should be done before using a building.
In terms of the filters, yeah, I mean, most buildings honestly don't have terrible circulation. It really is the closer areas. There was an outbreak in a German nursing home that was using a very energy efficient HVAC that would only bring in new air when the carbon dioxide level reached a certain amount. We don't have that in the US. We don't use those situations, right? And so it's we don't do anything special in the hospital particularly, but we use our general guidelines for air exchange.
Okay. Patricia asked, is there concern of toilet plume? How does this inform how we handle restrooms as we move to in-person services?
We have not seen a single proven case of COVID from toilet plumes. In theory, it exists, have not seen it happen. So I would put a relatively low priority on that.
Okay. There are a number of us who have parishes along the Pennsylvania border, and some clergy live in Pennsylvania. With Pennsylvania's higher positive rate of infection, should parishioners not cross the border?
It's really not where you go, it's how you go and what you do when you're there. So if you are driving in your own car with yourself or just a group of people, and you're not going to a big gathering and you're masking and social distancing, then it's a completely different thing than going over to your next town and going to a bar with a bunch of 18 to 22-year-olds, which is where we're seeing most of our infection. So it's really, the geography itself is really not what we find most telling. It's really gatherings of people without social distancing and masking.
Thank you. Is it true that people with type O positive blood are considered to be immune?
They're not immune. They may have lower rate of infection and they may have milder disease, but much to my mother's chagrin, they are not immune. Yes, she's clinging to that one and her BCG vaccination status, but no such luck.
Okay. Megan writes, I work in Ithaca where Cornell has been working with the vet school to do pool testing, which I understand has emergency permission from the FDA. How responsive is the pool testing?
Yeah, that's a good question. So it really depends. It's so variable. So we have looked at pool testing ourselves, and pool testing is just the idea of instead of running one specimen by itself, you get 3 or 5 or 10 people specimens together and you run them in one assay to reduce the number of assays used. And then if that pooled group turns positive, you have to individually take those specimens out and determine which one was contributing to the positive. We know it reduces sensitivity by a certain amount. We did submit our data to the FDA, just so you're aware. We got the data together towards June, when people coming in already had low levels of virus, and the FDA did not approve it. So there are now new requirements from the FDA that have significantly relaxed these restrictions. And so we're hoping to resubmit and look at pooled testing again.
All right, Alexei writes, the data vastly underestimates the majority of people who are not tested, which includes people of color, indigenous people, and poor rural whites. So why are you confident that over 40 million people aren't already infected now in the US when community health assessments already identified serious ethnic disparities in respiratory and pulmonary diseases and other comorbidities?
Why am I so confident? Well, I wouldn't say I'm confident about anything with COVID. I can just go based on the data and my own experience. We do significantly underestimate, especially in underserved communities. There's no doubt about that. But we also do surveillance testing. So for instance, in our area, we do, and Penn Medicine overall does pre-procedure testing for all procedures for COVID. So these are asymptomatic patients receiving pre-procedure testing. And I just looked at our data, and of nearly 7,000 pre-procedure tests that we performed, we had a total of 10 positives, giving us a asymptomatic community prevalence of 0.1 or 0.2%. And so, yes, there are populations. We have a very large Latinx community in Kennett Square working in the mushroom farms that had a horrifying outbreak. And I think if I went to that community, the prevalence would be, 40, 50%. On the other hand, this is a disease of communities, as Governor Cuomo said. It's really putting out local outbreaks, and we see our college students turning positive. But when we turn around on the other side, our nursing homes are no longer turning positive. And so it's we have underestimated our numbers, but based even on seroprevalence studies, which are looking at the presence of antibodies, there's really no area that has gone consistently over 5%. Maybe 10% in certain parts of New York City, but 65%, 60%, no, we're nowhere near close to that.
All right, thank you. Steve writes, for those of us who are trying to reopen churches, should we be preparing for shutting them down before Christmas?
That's a great question. I think that you need to plan in advance like we do with everything here. I don't want to say shutting anything down is the right thing, but maybe making provisions of services at different times with limited groups of people coming in with the right masking and personal protective equipment is probably a better approach.
Okay. Might it be possible that after a vaccine is available, that it might reduce the severity of COVID-19 if someone were infected?
Yes, we know with influenza that if somebody is vaccinated and they acquire influenza, we know the protection's not perfect. They tend to have milder disease. So it's certainly conceivable that a COVID-19 vaccine would function in the same way. We know from recent data as well that if somebody does become infected with COVID-19, but they were wearing a mask, and so maybe it came in through their eyes, or the other person was wearing a mask, that even when they acquire infection, they seem to acquire milder infection because of the lower levels of virus present. And so it's certainly conceivable that prior vaccination will lead to a milder infection.
Okay. Let's see, any other questions? Going once, going twice. I see someone waving at me. Do you feel that the companies doing vaccine development, whoa, okay, they're back, never mind. Do you feel that the companies doing vaccine development as well as FDA, CDC are holding to scientific or clinical standards and will be effective, safe when released?
I do. I have been listening in on the FDA's review process for vaccinations from well before the time of COVID. As an HIV doctor, we're constantly revising and updating our vaccine recommendations for immunocompromised patients. And the process is a very robust one and really occurs on independent channels. So as Mike said, at Penn, we do a lot of the work for the CDC, and we have statisticians in our midst who are actually working for the CDC group. So there's a group of scientists and there's vaccine trials at Penn who are performing the actual vaccine trials, and they're actually blinded completely to what the patient's receiving. We actually have no idea. We volunteer for a vaccine trial. You're one of the primary investigators. You don't know what your patient is getting. And then the data actually ships off to a separate place. It's not even geographically in the same place, to another group of people who then don't know the patient's name, but are unblinded and review the data independently of who's received the vaccination. What we're not going to have is a whole lot of experience with the vaccine, right? That's what we're not going to have. So we're going to have that basic foundational safety. But a lot of vaccine events happen after many people receive it. And so we're not going to have that experience part of it. And so I agree, it's not nearly as reassuring as getting your shingles vaccine, which went through the old-fashioned process of safety and monitoring. But I do not personally feel that we are cutting safety standards based on any other vaccine development. I think the real difference has been the actual scaling up of the process. So all these vaccines that are currently in development already have methods to scale up mass production, which we never did before. We would save our money and see which one worked first and then work on scaling it up. And that's something that's different this time.
Okay. Brooks asks, any advice on how to have conversations with people who refer to experts and put the community at risk by refusing to follow the guidelines?
It's a very difficult conversation. I think we're not asking much from people when we say wear a mask and socially distance. And so it's really hopefully keeping yourself and your community, your small group, as safe as possible, and preventing those who take increased risk from coming into that circle as much as possible, I guess, is probably the best way. Or if they, we have people who come to the hospital, visitors, for instance, who sometimes will refuse to wear a mask. And we have these difficult discussions with them. And the vast majority of them might be kicking and screaming, but we'll put it on ultimately. And will want to be here and interface with us with certain modicum.
Mm-hmm. Tom asks, do people taking an antiviral like acyclovir have additional protection?
No, acyclovir has no activity against SARS-CoV-2.
Should family groups from the same state get together for Thanksgiving? That might be a loaded question. It might be about COVID and other things, but you go ahead.
Exactly. You're planning to see Mike? Yeah. I think there's going to be a lot of transmission in family groups. Okay. I do. And I think that transmission is going to occur in the 19-year-old. I have a list of employees who were exposed, and it was all their 16-year-old, their 19-year-old, their 15-year-old, their 21-year-old, their 22-year-old. And they're completely asymptomatic, and they have, and you really don't know where they've been, and so they come in and they have no symptoms and they infect the group. When I look at our employees who turned positive in the last few weeks, almost everybody's been under 30. And they've had almost nothing in terms of symptoms at all.
What are the prospects for long haulers who have severe disease over a prolonged time?
We don't have a whole lot of experience. We do have a few employees here who we would count as long haulers. And it's very hard to tease apart exactly what's causing this constellation of symptoms. And they're extremely diverse. I do think almost everybody has slow improvement at different rates, some more than others. But I think I can't help but feel that a component of the long haul syndrome is the isolation and the stigma associated with having had COVID-19. We do have a clinic at Hub downtown where they work with these patients. And I think a large part of the benefit comes from having a community of others who have gone through this.
Okay. Let's see. Kit writes, you mentioned PPE being at bedsides, recommendations for clergy and patient visits, particularly to ICU.
Yeah, so it really depends on how much oxygen the person's on. If they're on a very high level of high flow oxygen, or they're on mechanical ventilation or BiPAP or CPAP, we would recommend, at least for us, that you wear a fitted N95 or respirator. Now, most of you have not been fitted. And so really in those situations, the options are to do it virtually if at all possible, or to wear something called a PAPR, which is a positive airway pressure respirator. Essentially looks like a astronaut's helmet, and that you don't have to be fitted for. And we have a number of those that are available. That's if they're on high level of oxygen, CPAP or BiPAP. If they're on a lower level of oxygen, it's a surgical mask. Eye protection, people don't think that's really, really important. This is what I wear. Spent all day in the hospital looking like this. Very effective. Okay, so wear my mask, wear my eye protection, usually on top of my head like this. And then we say gown and gloves, but honestly, the gown and gloves are not the big thing, right? It's hand hygiene, but it's the masks and the eye protection. And really, truly, I mean it, the patient should wear a mask. Mm-hmm. Source control is by far the most important part of preventing transmission.
St. Paul's said, ask a mask resistor if he covers his mouth when sneezing. Most people do so. The reason for it is the same as wearing masks. So yeah, that's one way of dealing with it. Mm-hmm. Toppy asked, when you test negative, are you safe from giving and receiving the virus?
So if you get a PCR test that's negative, the negative predictive value is very good. So you certainly don't have infection. I guess you're talking about, so here's the problem. So if you've been positive and then you test negative, you're probably immune for some period of time. If you've never tested positive and you test negative, we know, unfortunately, that you could be in this period of and if you look at that chart in the beginning, the viral load goes up logarithmically. And so we know in a period of 12 hours, 24 hours, people can go from having a negative PCR to high viral load. So at that exact point of time, and maybe for a few hours around it, you can't give the virus, but I can't promise you the next day you're not going to be contagious.
Sorry, UPS is delivering and I'm being protected by my dogs. Do you have any sense of the percentage of those who end up as long haulers?
Almost everybody has persistent symptoms. So the majority of people, when we look at study after study, almost everybody will have some residual symptom of some variety. It really depends on when you start calling them long haulers. We estimate that months, probably 10 to 20%.
Patricia asks, are you concerned about college students returning home for Thanksgiving break? If the college has a low rate of infection or low positive, does it make any sense for these students to self-isolate for 2 weeks upon returning home?
I worry about that a lot. We see a lot of transmission within college campuses and young people. So again, low rate of infection, negative test, does not, of course, mean that that particular person is negative. They can have very mild symptoms or be asymptomatic and have their test the day before they become contagious. So it really depends on how susceptible you are, your tolerance of risk, who's in the family and the household.
Okay. None of the local hospitals allow outside clergy visit, Chuck shared. And then Kate, just a reminder that community clergy are limited their visits. Please check with your local hospital. Right. Well, Dr. Akhter, you have answered so many good questions, and I really am so grateful for you being with us. And I feel like I'm much more prepared to answer questions, so I feel good about that. I think the clergy will too. And so I want to ask you, what is a role that you hope that churches will play in addressing COVID-19 or SARS? How might we be part of helping be the solution rather than novel places where groups get infected?
I think the isolation of the positive person is profound. I had a young woman who turned positive, who went to stay with her grandparents after she had her incubation period. And literally the community that the grandparents lived in almost like put her out. And we see this all the time. I had an elderly couple who had just sold their home and moved to a retirement community, and they both contracted COVID, and they were begging to stay in the hospital. And and when I asked them why, they said, we're going to be social pariahs, we're going to be lepers when we go back to this community. And it's a terrible thing to be sick, to have ongoing symptoms, to be human and maybe have made a mistake or maybe not, and to feel like you're a persona non grata after that. And so I think that is an enormous role of the religious community at this point, is to embrace, welcome, make them feel safe and not infectious. I always make a point, and maybe it's not the right time, but whenever I see my HIV patients, I'd make a point to like hug them and kiss them. And, and then I had some of the guys like start kissing me on the lips. And so I had to back down from that a little bit, but maybe that's a part of it, take somebody who's recovered from COVID and bring them up and say, and really, honestly, I mean it, they're the safest people to be around. They can't transmit it. They probably can't get it for a good long period of time. When I had to hire caregivers for my 91-year-old father-in-law, I hired 2 women who had COVID because they were not going to bring it into the household. And so giving that kind of empowerment and voice to those who have recovered and their experience of it, I think is really important.
Well, thank you so much again. It was really nice to meet you, and I'm very grateful for your time here today. And thank you very much. For all of you, the clergy will be meeting next week at 4. And in the meantime, may you be blessed and be a blessing, and may you know that you are loved. Thank you, Dr. Akhter, and goodbye to all of you. Thank you.